Welcome, everybody. Welcome to the ViiV Healthcare European Virtual Community Event for Common Health, Common Goals, Unite Against HIV Stigma. So how can we as a community unite against HIV stigma? My name is Emma Appiah. I'm a Regional Medical Director at ViiV Healthcare, and I'm just going to start off the proceedings of the meetings. So welcome. So just to get you familiar with the platform that we're using, feel free to ask questions using the chat box, chat icon there. Any questions or comments we hopefully will be able to address at the end, towards the end of the session. This community webinar is going to be recorded, and then it will be shared on ViiV Healthcare's website after the event. And please make sure to look out for the feedback. There'll be an evaluation form at the end of the event for you to provide your feedback, which will always be useful for help us improve on these events moving forward. But just to say that as a pharmaceutical company, we take the safety of our patients seriously. So if any side effects are mentioned during the meeting, we will be coming back to you to report them. And if you go to the next slides, just to say that you're automatically muted for this meeting. But like I said, if you do want to ask a question, then use the question tab, add interaction, and also there's an interpretation channel. So I'm going to hand over to Perry Mohammed, who is the Regional European Medical Director at ViiV Healthcare, and he's going to start us off. Thank you, Perry.
Thank you, Emma. So as Emma said, my name is Perry Mohammed. I'm the Head of Medical Affairs for Europe. Really warm welcome for those who've joined on the webinar. I think this topic on stigma is something near and dear to all of our hearts. And it's something we've been battling for the last 40 years, how to get a stigma-free society when it comes to HIV. We've made huge progress over the last 40 years, from the early days of the AIDS epidemic to where we are today. People are now having access to antiretrovirals, they have living better quality of life. But at the same time, we know that that does not lead necessarily to improvement in every aspect of everyone's life who have HIV. So a lot of work to do in this space still. We have tools at our advantage and at our disposal. We have the message of treatment as prevention, U equals U. You'll hear lots more about that from Bruce coming up. We have PrEP now as well, but at the same time, stigma is still here. And the question is, how do we push the agenda forward and expedite the way people within themselves have internalized stigma versus what within key populations, what stigma means for them as well. And then in the wider society, how do we tackle stigma around HIV? So hopefully today we will touch on all these different topics. So we all have our own definition of what stigma is and what it means. This word cloud that you see popping up on the screen right now was collated based on feedback we got at the last HIV Glasgow conference a few weeks ago. And we asked people at the conference, how can stigma impact someone living with HIV? And these were some of the themes that came out. And you can see there are lots of physical aspects of stigma and how that manifests. But a lot of it really is on the social aspect and the psychosocial aspect and what that can do to someone who is living with HIV. So bearing this in mind, if we can go to the next slide, we can get into the agenda. I'd like to introduce the expert panel. We have from the ECDC, the European Centre for Disease and Prevention and Control, Tema Nouri, who will tell us about the landscape of stigma and where we are today. Then we will also hear from Dr. Remy Shah, who's from ViiV Healthcare, and Dr. Andrew Clark as well, who will take us through a case study and then some of the physical impacts of people living with HIV when it comes to stigma. We'll also hear through video from Daniel Cordner, who's an artist from Australia, who expresses through his art what stigma means for him, and it's a very impactful piece as well. And then we'll wrap up at the end with Bruce, who will talk to us about U equals U at the same time. Next slide, please. So, like as well, that's the agenda I think I just went through. Just to let you know, I will not be here at the end because I have to catch a plane to get back to London. So Emma will actually be closing the meeting and taking any questions at the end and moderating. So with that, I'm going to hand over to Tema to tell us about HIV stigma and where we are now.
My name is Daniel. I'm a graphic designer, artist, activist, bike rider, nature lover, vegetarian, and I'm also living with HIV. HIV does not define me any more than the other qualities that define who I am. It is just one part of who I am. I am one of the 38 million men, women, and children in the world living with HIV. Today, I'm here to talk about stigma, the damaging effects of stigma, how we can begin to dismantle stigma, and the powerful narrative we can create in talking about stigma through art. I've chosen art as a way to tackle stigma, as I feel it's an incredibly powerful narrative. The visual art is another form of communication, a non-verbal communication. It's an incredibly powerful tool to express concepts and often complex ideas within the HIV community. Throughout my life, I've been inspired by artists such as Keith Haring, David Warrich, David McDiarmid, and the ACT UP campaign. The power and the significance of this artwork shaped part of my youth and also allowed me to see a way to express really powerful messages through visual arts. For me, visual arts allows many people to access this conversation and to engage in a way that they may not normally engage. With visual arts, you engage with the artwork. You can interpret the artwork how you wish, as opposed to perhaps reading a dense document or a report or hearing somebody speak to you. You get to engage with the artwork and you get to feel and respond how you wish. For me, this is the significance and the power of the visual form in the context of discussing key topics and narratives with HIV. It allows people that may not normally access this conversation to begin to engage in a non-threatening way. When it comes to art and activism, there's been an incredibly strong, rich history of artists that have worked in this space for a long period of time. Some of these artworks have been relevant to the time, and that may have been in the early parts of the epidemic. Some of those artworks were incredibly raw, incredibly powerful, and incredibly dark, and incredibly significant of what was happening at that time during the epidemic. When I was asked to create artworks around stigma for the catalogue, I decided to take a different approach. I wanted to create something that had a sense of optimism, a sense of life, and a sense of joy. I understand that's not everybody's HIV story. I really wish it was. I wanted to take this chance to show people that HIV doesn't have to be about the pain and the trauma and all of those difficult things we experience. I wanted to present ideas and artworks in a new light that showed a sense of hope and optimism and growth. One of the artworks that I'd like to talk specifically about was titled A Seat at the Table. During 2021, we had a series of webinars, and in those webinars, there were two key people from the Indigenous population. One of those members spoke about getting a seat at the table. As a gay man, I've never had trouble getting a seat at the table because our voice has always been heard. And I realize that there's so many people whose voices are still not being heard. I decided to take Leonardo da Vinci's famous Last Supper and do a modern interpretation of that. I decided to include diversity of sex, diversity of race, and I also put an Indigenous member in the centre. I felt like it was time for other people to step back and give these people the spotlight and give them the chance to be heard. So the significance of this artwork was to allow those people to have the spotlight and to finally be heard. Another piece I'd like to talk about specifically today was called the Tim Keys. There's a closed Facebook group called the Institute of Many, which is commonly referred to as Tim. I decided to create an illustration of keys where the actual locking device of the key said Tim. The significance of using these keys was once you have access to this group, it's almost like you're given the keys to a space where you can actually be yourself. The significance of this is being in these spaces is where you can start to let go of some of the stigma that we all carry. You're in a safe space, you're not judged, and everybody has a story to tell. So the significance of these keys is almost like a secret key to a club that only HIV positive people have access to, that allows you to enter a space, to enter into a discussion where you no longer have to fear judgment and people rejecting you based upon who you are, what you've done, and what virus you live with.
So I told you it was worth it. And we get another section of Daniel later on. So I'm going to hand over now to Dr. Remy Shah and Dr. Andrew Clark, who also work for ViiV Healthcare, and they're going to talk about what do we need to know about stigma. So handing over to you, Remy.
Hi, everyone. Thank you very much for inviting me today. And we're going to do a little bit of a double act. As Amma said, I work for ViiV along with Andrew, but I'm also lucky enough to work still continue my practice as a doctor. So I still work 1 day a week at a hospital in London. I'm going to present a little bit of a case that I was involved with a very long time ago. And then I'm going to hand over to Andrew, who's going to talk a little bit about the real impacts of HIV-related stigma in terms of health and well-being. But I think before I start, I just want every single person in this audience really to think about a time when you last felt different. And just think about if you were made to feel bad for feeling different. Just think about what it made you feel. Did it make you feel anxious? Perhaps it made you feel shamed. Perhaps it made you feel fearful. Have a think a little bit just about that for a second. So my point with that is that I think that basically every single person in this audience has felt at some point some kind of stigma. And unfortunately for HIV, people living with HIV actually will have experienced at some point, it is inevitable that they will experience stigma. So I'm going to introduce you to George. So George, when I first met him, was sitting, this is a picture, it's not actually him, and I'm going to call him George, but it's based on a case that I looked after, as I said. And George is very sick, you can see. He's sitting in a hospital, he's lying in a hospital bed, he's requiring oxygen, he's actually requiring a tube to help him breathe. And this is a picture of what his x-ray might have looked like. And a normal chest x-ray would actually look like the lungs would be black. But here you can see there's lots of fluffy shadowing, what we call interstitial infiltrates. And this basically means that he is riddled with a pneumonia. He has a really dense pneumonitis. And if we took washings from those lungs, then basically it would look like this. It would, if we stained this and looked underneath a microscope, we would see these sort of, I guess, fried egg type cysts. And they're basically cysts related to pneumocystis carinii. So George, as you can see here, has PCP related normally to advanced HIV infection. George was a 26-year-old IT specialist, and he'd originally come from Ghana, but has lived in the UK for many years now and has made his life here. He was previously, when we met him, on effective antiretroviral treatment. And but as you can see, he was admitted with severe PCP because he'd stopped all his medication and disengaged with care. And his counts when he come in showed how advanced his HIV infection was now. His CD4 count was very low at 100. His viral load was 500,000. And his oxygen saturations were 86. And this is really low. So every single one of us, at the moment, our sats are probably going to be around 96, 97, 99. So these are very high. So what made George get to this stage? This is a picture of what George might have looked like. It's a model, but maybe 18 months previously. But you can see he's full of life. He's basically a young man full of vitality, full of hope for the future. And what happened to get him to a hospital bed, lying there requiring a tube to breathe? Well, let's go back a little bit. So when we first met George, he was in love. He actually proposed to his girlfriend over 1 year, whom he had met in the church choir. And the church was a very strong part of both of them. It was a huge, faith played a really big part. But as part of the church's regulations, they mandated that they had a premarital HIV test. And so both of them went to their respective GPs and had a test. His fiancée tested negative, but George went to see his GP, and much to his shock and surprise, he tested HIV positive. Now, this was hugely shocking to George. He didn't know what to do. He didn't feel he could tell anyone. The only person at that point that knew about his HIV infection was his GP, who persuaded him to go to the clinic that he'd referred him to. And there he went straight away, and had some blood tests, which showed that, in fact, he had quite advanced HIV infection with a CD4 count of 120. His viral load was around 6,000. And in keeping with what was needed at the time, he started his antiretrovirals. He was also referred to a health advisor, a psychologist, who worked with him to try and help him through some of the feelings of complete despair, in fact, that he had. And he wanted to also be able to talk to someone, ideally his fiancée, about what had happened. But he felt he couldn't because of the shame that he felt. Eventually, he was able to pluck up the courage to talk to his fiancée. And so he told her about the HIV, but she was incredibly shocked. She was very, very frightened. She was angry. If she felt that he'd been unfaithful, what had caused this HIV? And she also felt, because she was so frightened, she had to talk to someone as well. So she talked to her friends, a couple of her friends, who then unfortunately talked to other friends, who then unfortunately talked to other people. And very soon the news was out that George was HIV positive, and it had spread through the community and unfortunately back home to his family back in Africa. So by telling one person, there was unintended disclosure. This resulted in a number of things happening. His friends, his family all turned against him. They were shocked beyond belief. They felt he had brought shame onto them. Even his church turned their back against him. And the family said that because of the shame that he had brought on their family, they didn't want to know him. His father said, "You are no longer my son." This resulted in slurs on his character and even death threats from the family back home, friends of the family back home in Africa. All of this meant that George felt more and more isolated. He became increasingly low in his mood. And then, unfortunately, his relationship also ended as his fiancée felt she couldn't cope. She didn't want to be part of this. He started to not go to work. He felt that he couldn't tell anyone at work because he was afraid of what would happen if he did tell them. And unfortunately, because he started just being quite haphazard when going into work, he actually got fired from his job. This resulted in even more depression, even more isolation, and feeling even more alone. And he fell into a deep depression. And he thought, what was the point? What was the point of taking his antiretrovirals? What was the point of going to the clinic? So we stopped seeing him. In fact, we didn't see him for many months until he was eventually admitted breathless. As we see, he was admitted with his PCP. But PCP, as we know, is actually treatable if you get it early enough. We can treat it with antibiotics, we can treat it with steroids, and we can restart the antiretroviral treatment. And because, remember, George was very well and healthy prior to this, so he responded well. He had a good CD4 count response, and his viral load became undetectable fairly quickly. He also agreed to see the psychologist on a more intensive level, and he had psychotherapy, which improved some of the stigmas that he was feeling, gave him tools to deal with this. And he was also started on antidepressants as well to try and help him through all of this. But what we can see, I hope, by this case is that there were actually multiple sources of stigma here. And if we look at them one by one, we can see, first of all, there was the internalized stigma, the stigma that came from within, from his own thoughts and perceptions around HIV itself, and this all stemmed from his own mind. At the same time, he was expecting stigma, not only from his family, his fiancée, and his church, but at the same time, he was also anticipating stigma from back home, from the workplace as well, so he couldn't tell them. And of course, he experienced this stigma. And this again came from family, friends, his community, everyone pretty much that he knew, again, based on the discriminations that he felt, and all against a background of sort of ill-conceived knowledge about HIV, negative prejudices and negative stereotypes around HIV. And all of this, therefore, resulted in the fact that he had overwhelming feelings. He felt shame, he felt low self-esteem, he felt isolated. He also felt fearful, not just of the present, but also of the future. And this impacted both his physical health with the PCP, but also depression. So in short, you can see lots of different types of stigma. And all of this meant that basically it could have both short and these long-term adverse health threats. But what it did mean was that this can often be very overwhelming for any person dealing with HIV stigma. And we need to look at some of the impacts of this that it may have on health and well-being. So with that, I'm going to hand over to Andrew to continue to tell us a little bit more about that.
So I'm going to now just cover some of the actual physiological and biological consequences of what stigma does, mainly as a chronic stressor, but hopefully you'll get a good sense that stigma is more than just a social construct or a social toxin. It is actually a directly harmful entity. So we sense adversity and have evolved to sense adversity in a number of ways, primarily how we see, hear, or feel something that's adverse. So something that might be painful, or something, if you see a fire, or you hear a noise that is associated with something that might eat you. These are all ways that we sense something that could be harmful to us. We also have an internal sensing system in our immune system, because our immune systems can sense when we have been invaded with some pathogen or other. So that gives us another way that we can sense that there's something adverse that we need to react to. And then there's a complex interplay between the brain, the peripheral nervous system, the immune system, and the neuroendocrine system as to how these adverse events play out. And it depends on what they actually are as to how we then respond. And ultimately, that will tell us whether we need to stick it out and fight, or in fact, get the hell out of there, because whatever it is dangerous. And that all then sets off this huge, big interaction that starts off with the brain either telling you to move and run, or to fight, or the internal processes where you have this massive onslaught of hormones that essentially tell your adrenal glands that you're in trouble in some way. And this sets in motion both a nervous, an endocrine, and an immunological response. And so this is a very old evolutionary process that keeps us safe. Now, this is all just meant to be a single episode, and it's tightly controlled, and it has to be regulated, because inflammation can also be harmful. So you need to have it come to an end. Now, the problem is that in some cases, that event does not go away. And stigma is one of those things that doesn't allow you to settle down from your adverse event. And even more alarmingly, stigma isn't just a single entity, because essentially it is a discredited identity that a society deems is not desirable. And those things can change with societies, they can change with individuals, they can change depending on your status in society, your level of poverty, your level of education, the language you speak, the religion you adhere to or don't adhere to, etc. So there are multiple different ways that stigma can either be sourced or endorsed or created. And very unfortunately too, people who have HIV can have multiple different simultaneous sources of stigma because of other discredited identities. And so there is no one single stigma that you can then escape from, because you now have all these other avenues of stigma. Now, specifically, when you think that either our population with HIV is aging, or older people are getting infected with HIV and then presenting. And you can just see this is just recent new cases of HIV. But there's a particularly important aspect of aging with HIV and a life lived with stigma and a life lived with the consequences of stigma, because these are cumulative. And it's really important to understand that we are sitting on a potential tsunami here of comorbidities because of the chronic inflammation caused by HIV itself, the social stresses that people living with HIV have to experience, stigma amongst them, and then also aging on top of that. So it is really important to understand the consequences of stigma and how this intersects with the consequences of having HIV and the consequences of lifelong stresses. But there are multiple types of stigma, as I've already mentioned. And Ruby has just mentioned some of these as well. So there's this anticipated stigma, that, you know, the belief that you're going to experience stigma. There's the experienced or enacted stigma, as you've just seen from this case, where you have an event of discriminatory action, or an event that you can recognize as being undesirable. There's the internalized stigma, where you yourself might feel ashamed about this discredited social identity that such as HIV, where there's that internal shame that you have something. And then there's also the intersectional stigma, where these are all layered one on top of the other. And that means that, you know, it's almost inevitable, as Remy mentioned, that at some stage in your life as someone who's living with HIV, you're going to experience stigma. And ultimately, this all leads to this chronic stress response, which starts off with an action in the brain that will tell the nervous system to do something to make you run or fight, which is the autonomic nervous system, and that's the sort of adrenaline effect, or this hormonal route, which you need to fight the response internally, so either an infection or a psychosocial stress where you can't necessarily run away from it. But those two are meant to be episodic. And so when they are chronic, this is where the trouble starts. And so with these different types of stigma, and they can be measured, so there are ways of measuring these different stigmas and quantifying them and qualifying them. But they do have different consequences. And while they may be interrelated and some of the consequences are interrelated, you can also tease out some of the things that are more likely to happen when you have one or other form of stigma. So experienced stigma can have a direct effect on physical health, because that's a direct stressor. And so we know that stress has consequences for health across multiple different responses. Then there's the perceived stigma, which is very closely related to internalized stigma, and that affects, in a more subtle way, potentially affective your mood. It affects your cognitive performance and has an adverse effect on mental health. But it can also mean that you would avoid those situations. So you might avoid healthcare, for instance, if the healthcare is a source of that stigma. And then anticipated stigma can also change behaviors in terms of things like avoidance, but it can lead to loneliness and isolation. And that is really, really problematic for young people in particular, and old people. But these multiple sources of stigma can actually converge. And ultimately, there is no escape. It doesn't mean that it's always going to have an adverse outcome, because people have different ways of dealing with this. So you have, first of all, vulnerable populations, which in themselves can be stigmatizing in some jurisdictions and some regions. So women, for instance, men who have sex with men, transgender communities, adolescents sometimes can also be stigmatized because they don't have much social currency yet. The elderly in some settings are particularly stigmatized. Sex workers, for instance. And then there's the socially deprived, so poor people, people that have been to jail, people that are homeless, people that are immigrants in a different society. You have the stigmas that are associated with the risks of acquiring HIV. So those people that are more at risk can be in themselves stigmatized. So once again, men have sex with men, intravenous drug users, sex workers, people who have other sexual orientations, people who may want to avoid HIV. So there are all sorts of different stigmas associated just with those groups that are more at risk of HIV. And then there are different forces of those stigma that are either endorsed or created or caused by the religions that they belong to, the cultures that they are in, and the ethnic groups that they belong to. And then there's also stigmas around neuropsychiatric conditions. So people who have anxiety or depression could be stigmatized in themselves. And substance use is another stigmatizing activity. And then there's all the unavoidable issues in an environment that really, unfortunately, are potentially ubiquitous and pervasive. So state discrimination or state laws or just state culture, intimate partner violence in a setting of a relationship. People who belong to one group might not have access to all of the amenities like healthcare, and of course, in the setting of war or community violence, people's individual rights often just disappear. So all of these really have a very profound effect on people living with HIV, and unfortunately, they layer one on top of the other, as I said before, giving you this intersectional stigma. Now, there's a very clear link between stigma and all the different forms of stigma and the different avenues that stigma arise from, and stress response, as already mentioned. And that chronic stress response causes this outpouring of inflammatory chemicals that we call cytokines. And these come from cells that usually are used to just dealing with an infection or an episode of an imbalance of some sort. But if you have long-term and chronic stress, then that results in this persistently high level of cortisol, and that results in now a dysfunction in this normal, very good immune response to deal with some kind of inflammation. But of course, this doesn't get switched off, and that ultimately gives you this issue that we call systemic chronic inflammation. And that comes with a whole host of other comorbidities that are very closely correlated with the degree of inflammation. Things like cancers, like hypertension, like diabetes, like obesity, liver disease. So there's a whole host of diseases that are closely related to inflammation. Now, there are specific groups that are disproportionately affected by stigma. And I'll just pull out a couple of them because I think it's really important to think about the sheer impact that this has on these groups' quality of life and their survival. So the transgender community really stands out because way more than half people who are transgender have experienced discrimination or stigma in a public setting. And this affects whether they will seek healthcare. So, 1 in 5 won't because of mistreatment previously. Almost half have attempted suicide. More than half have some degree of depression and can be severe enough to result in wanting to commit suicide. This affects their ability and their access to employment, and also, therefore, there's a high amount of poverty amongst the transgender community. And this goes way back. It starts even when, if individuals identify as transgender at school, then this is where that mistreatment will start. So 77% of those who did already identify school had mistreatment at school. Half were physically attacked, beaten, or denied equal access to some or other care or treatment. And nearly a third are mistreated at work. And this has health outcomes. Now we see something similar, but depending on where they are, for women. So in certain instances, in certain regions, certain cultural environments, women have much less social currency. They are subjected to intimate partner violence. They are disproportionately the carers of families and have carer responsibilities. They may or not have a sense of belonging. They are more likely to suffer depression as a result of this inequality, and they can be rejected or excluded because of their gender. Now, there are examples of what this means from an HIV point of view. So nearly half, or up to nearly half of those who were HIV infected while pregnant didn't access care and therefore resulted in an HIV-infected baby. So if they didn't have stigma and had equal access to care, that might not have happened. And another example is up to 40% of women in a survey across 6 Asia Pacific countries were forcibly subjected to involuntary sterilization because of their HIV status. Children and adolescents, I mentioned earlier, also have a unique component of stigma, and the problem for these individuals is that they will have a life of stigma and a life of the consequences of stigma because they've started off as children. So if they survive into adulthood, they will survive with all the burdens of various forms of stigma that will have the same effect on them, but exacerbated because it's over such a long period of time. So they will have this feeling of shame and internalized stigma. The caregivers that look after them may not have HIV, so there's this disconnect between the carers and the individual being looked after. They don't have social currency, so they may not be able to engage with friends at school. They may be rejected at school. So there's a raft of different ways that these children are subjected to quite severe forms of stigma and social isolation. And that can exacerbate their ability to eventually care for themselves, so they're more likely to be in poverty or remain in poverty. Malnutrition is potentially an issue here as well, and access to services. So this is an example from sub-Saharan African study, but many orphans with HIV are cared for by relatives who may or may not have HIV themselves. And this causes a massive amount of discrimination, certainly within the family, but even in the community. And these children are very often excluded or find accessing care or amenities very difficult. Now, the other group to call out is the older folk. And I've already mentioned some of this. So people who are aging with HIV or who get infected as an older person when they first get HIV, they have a unique additional issue with aging. So there's an inflammatory process of aging, there's the inflammatory process of stigma and chronic immune activation from all the stresses that these individuals have accumulated over their lifetime. And then you add in the problems that of aging itself, or ageism, is another form of stigma. So someone who's coped quite well up until a certain point in their life can suddenly find that they're no longer coping now because of the additional effects of ageism. So there's much higher rates of depression, and depression that's related to loneliness and stigma. And unfortunately, older people with HIV are also accumulating bunches of comorbidities, and so they have a whole host of other problems that they really have to try and deal with. So stigma creates this hostile, adverse environment and has direct health consequences that are related to the stress response, chronic inflammation as a result of that, comorbidities as a result of the chronic inflammation, immune dysfunction, because that's essentially what chronic inflammation will do, and this will have effects on multiple other areas, but it is specifically including mental health. And so this ultimately will lead to individuals being very much more impoverished in some way, either physically or mentally or financially. And so these direct adverse environmental factors are really the sources of these additional forms of stigma. And you've already heard from the first presentation that healthcare settings are one of the sources of discrimination and bias and stigma. And that just to me is utterly unacceptable. But it could affect people's ability or willingness to then engage in healthcare. And there's so many societal factors, and I won't go through all of these, but some of these are really just unavoidable. And potentially as people age, that can then shift, but it also means people that are more vulnerable are even more likely to suffer from these different forms of stigma. And that chronic stress leads to a multitude of other organ system dysfunctions. Now we know, and we have known for a long time, that chronic inflammation leads to a host of other diseases, autoimmune diseases, cardiovascular diseases, diseases of the central nervous system, lung diseases, a whole host of metabolic diseases, including diabetes, musculoskeletal diseases, and cancers. And, well, you already know that all of these are overrepresented in people with HIV, and all of them are overrepresented in people who have lived a long time with HIV. So adolescents that were born with HIV and people that have aged with HIV. And so the underlying theme here is that this is closely correlated with inflammation and stress. So this long-term inflammation that is secondary to stress can have multiple impacts. So we can directly measure the impact of stress on wound healing, for instance. So we can see that there's delayed wound healing. We can show that stress also impairs the ability to mount a good immune response to a vaccine, for instance, to flu vaccine. We can measure the amount of stress and correlate that with the effect that it will have on viral replication and CD4 recovery, even in the setting of good treatment. So there's a direct correlation here that is measurable between stress and some of the factors that affect health outcomes for people living with HIV. And then finally, we can also measure some of the inflammatory markers that are associated with depression. And yes, depression is an inflammatory disease as well. So the inflammatory markers we typically see there are raised interleukins like interleukin-1 beta and interleukin-6 and other cytokines. But these specifically impair the function of some immune cells like lymphocytes and natural killer cells, and that further contributes to disease progression. And so what is the evidence that we've started seeing that specifically links stigma, not just anxiety or stress or depression, which is a surrogate for stigma? So we can see that, for instance, in this, the first one here, for menopausal or postmenopausal women, we see a differential effect of higher stress on some of the markers of accelerated aging, like something we call telomeres, which is how cells can, little bits on the end of DNA that allow cells to divide. And so when that's shortened, there's less capacity for that. So this particularly is shortened in women, postmenopausal women who have more stress. We can also see an outcome for men who have prostate cancer, and those men who felt more stigmatized or who felt less empathy from their physicians had worse outcomes in terms of their cancer. And in an HIV setting, we have demonstrated that older men who are living with HIV are more likely, if they have stigma, to have less cognitive performance on cognitive testing and worse mental health. So there's now an emerging body of data. But I mentioned earlier that children are particularly vulnerable, and there's something called adverse childhood experiences, or ACEs. And many children who come from backgrounds where they're more likely to acquire HIV, either through birth or through their communities, also come from communities where these adverse childhood experiences are also more likely, because they're more likely where there's poverty, where there's violence, where there's community disruption from war, etc. And these have a permanent impact on that child's future, because the way that these childhood adverse experiences behave is it affects the immune system, it causes an inflammatory activity, it results in a permanent change to how the genes of those immune cells are managed. And so it's not just an episode. That child is now doomed to this lifelong low-grade inflammation, and it affects their immune function, and they then have all these accumulative comorbidities that are resulting from chronic inflammation. And so when you throw HIV into that mix, you now have yet another cause for these comorbidities. And it's exactly what we see in adolescence. So when you mix HIV with those children who have had these childhood traumas or adverse childhood experiences, you really enhance the stress response through the hypothalamic pituitary axis that I mentioned right in the beginning. And this has a profound effect on child on adolescent and young adulthood behavior, but also on their immune functions and their ability even to adhere to antiretroviral therapy. We also know that those who come from lower socioeconomic status or environments are much more likely, as you can see on the graph on the right. This is from Australia. So this is intravenous drug users who typically do have a lower socioeconomic status. They are more likely to have AIDS and have a higher mortality, especially based on an initial low CD4 count and an inability to mount a good CD4 response to treatment. But people that are food insecure because of poverty are also much more likely to not mount a good CD4 response in treatment compared to those who are food secure. And when we look at the lower left one, study from China, those who have a higher socioeconomic status are much more likely to achieve a good CD4 response than those who have a lower socioeconomic status. So once again, this is a discredited identity. Poverty is one of those stigmatizing identities, and it has an impact on someone's health outcomes. Now, we can also measure the effect of social stress on the immune response. And so this is quite a complicated study, but just try to put it into a nutshell. Essentially, what you're getting from this when you're looking at stressful life events, chronic stress, everyday discrimination, lifetime discrimination, or life traumas, you can see slightly differential effects on some of the measures of the immune system. Now, as we age, our immune systems deteriorate in a very distinct way. The cells that we need to continue to identify new pathogens that can be a risk to us start diminishing, and the cells that have memory of previous exposure to other pathogens start accumulating. So we have this accumulation of tired, old, exhausted, grumpy cells and a lack of young, fresh cells that can keep us safe. And that's a well-recognized consequence of an aging immune system. But what we see with stress is that it accelerates that process. And so what you see here is that these stressful events, lifetime discrimination, lifetime trauma, they start skewing the immune system to this aging phenotype where you have what I call a grumpy old immune system that's tired, it's exhausted, and is no longer going to be able to protect you to new threats. And that is extremely harmful. So there is an impact on mental health specifically, and I'll just get to there's just 2 more slides left. But that pathway is once again very, very much correlated with inflammation. And finally, just tying it all up, you have these common stigma triggers leading to inflammation, all the consequences of inflammation that we see in HIV. And so you see this intricate link between the different forces of stigma, the psychosocial factors that people are more likely to have in HIV, and these all collude independently to result in multiple comorbidities because of underlying inflammation. So hopefully the message is loud and clear that stigma isn't just a social toxin, it is directly harmful.
Thank you so much, Andrew. I think you made it absolutely clear. You brought to life the data that Tamer was talking about, and also some of the case study as well. That was amazing. So thank you very much for that. We're now going to go to a video by Daniel, again, talking about how he uses, how he tackles stigma with art, but also his hopes for the future. So I hope you find this video really interesting.
I feel that there's a really powerful way that we can tackle stigma through the use of art. It becomes a very powerful vehicle to discuss ideas and share concepts that are often complex to convey through the use of words. Using art in this context allows people to engage in the conversation in a way that they may not have beforehand. I can think of numerous people that I've shared my artworks with or shared the art catalogue with that has allowed them to understand HIV from an incredibly different context. They've entered in through a visual narrative as opposed to a written narrative. Often in HIV, there's lots of concepts and terminology and medication and things that I often find overwhelming and complex myself. And for somebody who's not living with HIV, that can be very overwhelming. I feel that the use of art allows people to interpret this in their own way and in their own space. They can sit with the artwork and it can speak to them, and they can interpret it and feel however they wish. Nobody's telling them what they need to think. Nobody's telling them what they need to feel. And that's one of the powers of artwork for me. Another key element of stigma is the fear. The fear of transmitting the virus, and also that people fear you. Once I overcame my own fear, and that also was at the time of U=U and PrEP, I was able to confidently let go of that fear that I carried for so long. I think the significance of events like today is to be having an open conversation around this element of stigma. When I was first diagnosed, it wasn't a discussion, not an open discussion. It was judgment and a real lack of understanding. Well, we've come an incredibly long way with HIV and effective medication and wonderful conversations. There's still a long way to go to break down stigma, which is actually, if not more damaging than the virus itself. As we all know, the virus doesn't judge. It's people that judge. I believe there's some really powerful lessons that we can learn through tackling stigma. Some of the ways that we can tackle stigma is primarily to listen. For me, it's been really powerful to have so many people around me hear my story and to understand the lived experience. By speaking about HIV, it allows people to be educated and to also learn things that they maybe previously did not know, such as U=U, undetectable equals untransmittable, or even there's medications such as PrEP. Stigma also meant that I lived in fear for a big part of my life. Living under that blanket of fear also meant that the experiences I had were not the ones that I wanted to have in life. I shrank back, I retracted, and I didn't engage in life because I was living a life of fear. This is what stigma does. Stigma makes people scared of the interactions you have. It makes you scared of what people think of you, and it makes you scared of what people will say about you after sexual encounters. Through working through my own internal stigma, I've now overcome those fears. And by overcoming those fears, it's allowed me to be here today. I never once thought I'd be sitting here in this context talking about HIV so openly, and also talking about creating artwork within the HIV community to continue this ongoing narrative. I feel incredibly humbled to be invited into this space and also to be able to share my story and my art so openly and so freely. I can only hope that by doing so, that I act as a role model, or maybe in hope inspire other people to take that same step. Taking that step is not easy, and I would never negate the challenges and difficulties that I've faced and that so many people face to get to that point. But what I can say, and what I do know from my own experience, is that overcoming fear, letting go of stigma, has been one of the most powerful things that I've ever done. I have some great hopes for the future around HIV and tackling stigma. I hope that one day we'll be in a place where everybody can be treated equally, regardless of their status. I dream of a day where whether you're HIV positive or negative no longer matters at all. I hope for a place in a time in the future where stigma doesn't erode people's lives, where stigma doesn't hold people back, and where stigma doesn't cause people to make decisions in life that they may not have made if they didn't receive a positive diagnosis. I also hope for a future where there's no new transmissions. I think when that day comes, and I feel optimistic about that future, that stigma will also start to dissolve. But as we can see, we've been at this for 40 years and we still have a long way to go. But I feel hopeful and optimistic about the future. I can only hope that in any small part that I might be able to encourage or inspire people to take those same steps. That's the future I hope for, that people can let go of fear and live their truest life and be the person that they've always wanted to be, regardless of their status, regardless of stigma.
To hand over to somebody who has used his voice extensively against stigma, and hand over to Bruce Richmond, who's going to talk about some of the work that he's done using the amazing U=U message. Thank you, Bruce.
Thank you so much, Amma, for the introduction, and thanks so much to ViiV Healthcare for inviting me here today and for everyone who's participating. Today, I'm going to talk about U=U and how to use this to progress towards zero stigma. So how do we use U=U? But first, I'm going to talk about and really kind of acknowledge the folks who created U=U. There were so many activists and researchers, healthcare professionals, health officials who joined together with us, really collaborated with us for the following three goals. First, our goal was to create a consensus that U=U was indeed true. And we achieved that. Now we know that the global medical and scientific community has endorsed U=U without a doubt. There is no controversy over that. And now we're really working on goals number 2 and number 3, which is to disseminate U=U, the widely unknown science, which is still not getting out to many parts of the world. And so it's great we're here today to talk about it. And number 3 is to advocate to make sure that everyone has the potential and the opportunity to get to U=U. Because when people with HIV can sustain and maintain U=U, we not only stay healthy, but we can't transmit HIV. And this is the key to ending the epidemic and to saving lives and improving our lives. So let's take a look at why U=U is so important. It's really important to revisit this. Often folks sort of pigeonhole U=U into anti-stigma or improving the lives of people with HIV, which should be enough, right? Making sure that people with HIV know about U=U and have access to benefit from it greatly improves our social, sexual, and reproductive lives. Now that should be enough of an impact, right? But there's more. It also reduces, and what we're talking about today is the stigma, the way that we feel about ourselves, the way others feel about us, the way decisions are made about us in policy decisions in healthcare and education, employment and housing. And it's really important that there's data now that show that U=U accelerates all of our 95 goals, the treatment cascade. There's research, which I'll show you in a minute, which shows that U=U increases HIV testing rates. It also accelerates our people with HIV adhering to treatment and engaging in care and becoming virally suppressed. And I'll show you that study as well. And we're seeing that U=U is being used to modernize discriminatory laws, policies, and practice. We're seeing criminalization of people with HIV is being modernized all over the world. We're seeing people with HIV can be married for the first time in Oman. People with HIV can serve in the military in the UK now. And we could advance in our careers in the United States, but we still can't serve in the military in the United States. It's incremental change, but we're seeing this all over. And there are laws and policies that need to be reformed on virtually in virtually every country. There's so much work in this area and so much potential for U equals U to make change in this area. And then finally, and last but not least, certainly, is that this is a public health argument. This is a universal access argument, because now we know when people with HIV have the treatment and the care and the services we need to stay healthy, this is not only good for us, but this is essential for ending the epidemic, for strengthening economies, for public health and safety. There's so many benefits. This is what we call the win-win approach. Now, I've been living with HIV for almost 20 years, and this is the most exciting time, the most hopeful time that I've ever experienced for people living with HIV, because now we can say that when we're healthy, that's good for everyone. That's a win-win. So investing in people with HIV, investing in our quality of life, is the key to ending the epidemic, and has so many benefits for countries. It's a very exciting time. Also very exciting is this pioneering study by ViiV Healthcare called Positive Perspectives Wave 2. I was really honored to be a co-author and be involved in this study. It showed that when healthcare professionals inform their patients living with HIV about U equals U, there are tremendous positive health incomes in terms of overall health, mental health, sexual health, viral suppression rates, adherence, and sharing of status. So people who were informed, adherence is really important, were 3 times more likely to be adherent to their medications than people who are not informed about U equals U. So this is tremendous. So back to stigma. What's working around stigma? There's so much research on the extent of stigma and how bad stigma is, and we often hear speeches about how bad stigma is. Stigma is the greatest challenge to ending the epidemic. But let's hear about what works. So we did a literature review, and the reality is there's not a lot of data on what's working. And particularly, there's lacking data on social, cultural, and economic contexts of stigma and its specific interventions. And within these cultural contexts, there's a scarcity of well-designed studies on interventions, and we really need more studies on what is working. So that was the overall results of this recent literature review. So although there aren't a lot of studies, there's relatively few, we know that U equals U improves lives and is an unprecedented opportunity to reduce stigma. There was a small study in the United States of close to 300 women, including women of transgender experience, that showed 72% said it had a significant or tremendously positive impact on their lives when they knew about U equals U. And a large-scale study of over 30,000 gay and bisexual men, men living with HIV, said that U equals U made them feel at least a little bit better about their own status. So there's progress there, and that U equals U had the potential to improve societal HIV stigma. What we are seeing, though, is, despite this progress, some behaviors are not changing, particularly among gay and bisexual men on the apps. There's a recent study from Australia that showed although HIV negative men knew about U equals U and they believed it, that didn't really translate into behavior change, that they still preferred to have sex with other HIV negative or perceived HIV negative men than people living with HIV who had undetectable viral load. So it's going to take a lot of repetition over and over and consistent messaging, which we'll talk about later, in order to change knowledge into actual behavior. And as I mentioned earlier, there was a study in South Africa, a groundbreaking study that showed when men were informed about U equals U in testing outreach, they're almost twice as more likely to get tested for HIV than those who are not informed about U equals U. So it's really important to use this information in HIV testing outreach, and I'll show you an example of how to do that in a little bit. We're also seeing the most important medical and science and public health organizations in the world endorsing U equals U for its impact on stigma. The World Health Organization says that U equals U can have enormous benefits on reducing stigma, and PEPFAR agrees as well. And in fact, PEPFAR makes U equals U a requirement of all 50 plus PEPFAR countries in order for them to get funding from PEPFAR. They must have U equals U education. That's why for so many reasons. But this is more important to me really than anything, is just hearing consistent stories from people living with HIV around the world about how U equals U is changing their lives. Cheryl from the Seychelles talks about she's so excited to be free of stigma and discrimination. She has so much to look forward to. Catherine from Zambia talks about she no longer feels like a danger to other people, and she feels no longer bad about herself. Nestor from the United States, moving slide forward, talks about now being able to have a family. Claire from Rwanda, who's also now in the United States, talks about her U equals U babies. And Pete from Thailand says how U equals U moved him from darkness into light, and now he's living a full and healthy life. So how do we use U equals U to reduce stigma? Well, it's really about communicating U equals U in many spheres, to people with HIV, to people affected by HIV, to the public, policymakers, providers. So there's many different realms. And I'm going to show you some examples of ViiV's communications. Now, ViiV, and I'm not just saying this because ViiV is sponsoring this event. This is true. ViiV is one of, if not the most important leader in U equals U, and for so many angles around the world, from original research, like I showed you earlier, PP2, that's been shown everywhere from China to Russia to South Africa. It's been shown by CDC global presentations and the WHO presentations. I've been presenting it and seeing it presented everywhere, to other kinds of implementation research, this beautiful and creative award-winning PSA that I'm about to show you, social marketing campaigns integrating U equals U into advertising and testing campaigns, and funding so many U equals U programs around the world and trainings like today. So thank you so much, ViiV. I'm just going to show you some examples now of how ViiV is using best practices in communications, which you can use also. And on the left is an award-winning PSA that ViiV produced in collaborations with many NGOs in the UK. This PSA has actually been replicated in other countries. We've seen the same concept now replicated, which is what we want to see, not reinventing the wheel, but looking at great models like this and tailoring it for other parts of the world. And on the right is the commercial that almost everyone I know has seen in the United States on TV in primetime spaces. So just take a look at this.
And now there's something new you should know about HIV. A simple, happy fact. Thanks to effective treatment, a person with HIV whose viral load has reached and maintained an undetectable level cannot pass the virus on to anyone else. So there's nothing to see here, just people living.
And this tweet I absolutely love. It is so happy, and it is such a way to celebrate this incredible news.
What have these couples got in common? They're loving life and each other, safe in the knowledge that U equals U. Undetectable equals untransmittable means that if a person living with HIV maintains an undetectable viral load, they cannot pass on the virus to their sexual partners. The partner studies proved it. 112,000 instances of condomless sex with 0 HIV transmissions. Share the happy message of U equals U today.
And you can find that on social media in circulation. We absolutely love it. And here I'm going to show you, remember I talked about earlier the science that when you educate about U equals U and testing outreach, their testing rates go up. Take a look at this. This is ViiV's Tackle HIV campaign, educating about U equals U. This is something we hope to see in other parts of the world, but again, the UK is leading the world, and ViiV is showing incredible examples of what we should do. So how do all of us talk about U equals U? Well, there's tips that we've learned from the last 6.5 years from every country. We need to be crystal clear in the way we talk about U equals U. We need to be confident. We need to be consistent, and we need to be conscious. And I'll go deeper into each of these. But being clear, if we say these words on the left, this opens up the little window of risk. And that's like saying people with HIV are a smaller grenade, but we're still a grenade. We're still a risk. And that undermines all the benefits of U equals U. We really have to and can say unequivocal language like you're seeing on the right. We can even say zero risk and 100% effective. The world's leading experts and institutions are saying 0 and 100% effective. So that means all of us can. And if you ever feel lacking in confidence or feel uncomfortable, because it's hard to say new things, especially after 40 years of fear of HIV and people living with HIV, borrow confidence from the experts. Most of us are not experts in HIV transmission risks, but the experts are saying we need to say 0. And be confident. I mean, we hear this a lot on the left. And believe in U equals U, but use a condom or PrEP just in case. That actually means I don't believe in U equals U. But there's no shame in using a condom or PrEP, although they're not clinically necessary to prevent HIV with U equals U. We need to be clear about that. But condoms or PrEP could also be helpful to prevent other STDs or pregnancy. And you have that option. Or if a partner is struggling with adherence and could then have an increase in viral load. If there's lack of trust with your partner, familiarity, if you're meeting someone on a one-night stand or in a sex club and you don't really know their status or trust them. And there's no shame for wanting to use it for that added sense of security. This is one of the worst. So when people say you're only as good as the last viral load test, that's terrifying to many of us with HIV. That means I got my viral load results about 2 months ago and I was undetectable. But today, according to this, I could be infectious. So we're never safe. This is not something to say, and we've heard this frequently. What we should say is encouraging to people that take your medication as prescribed, get your tests done, and you don't need to worry. You can go and live your life. Medications are durable if you take them. You don't need to be afraid. And then there's the catch-all. Oh, I believe U equals U. You never know. Nothing's impossible. Nope. We do know. We need to be confident and say we do know. We also need to be consistent because change is hard. And as I said earlier, we're up against 40 years of fear of HIV and people living with HIV. And to make that cognitive shift requires repetition from credible sources and the right messengers. It's going to require many different targeted channels to get this message out repeatedly, many conversations. Many healthcare professionals have told us that this is such a joy to share with people living with HIV, such a meaningful information to share. And then we need to be conscious that our viral load does not equal our value. And there's many people around the world due to circumstances out of their control, sometimes by choice, but often by these barriers, that are not able to get to viral suppression, not able to get to U equals U to stay healthy and not pass on HIV. So we need to use that public health argument that I mentioned earlier to make sure people have access to the treatment and the care so that we are leaving no one behind, and we're underscoring that no one living with HIV is a danger. There's condoms and PrEP for happy and healthy sex for everyone with HIV, regardless of our viral load. So what are our next steps that all of us can take towards stigma? Well, we need to be encouraging those at the top, so governments and global organizations, to endorse U equals U and integrate this into policies and strategies and guidelines. We've seen some of the most influential countries and global organizations just erase U equals U, just ignore it. or sometimes pigeonhole it just under stigma and maybe define it once. That's unacceptable. Like PEPFAR, we need to make U equals U right up front and even a requirement in funding proposals. We need to educate at every opportunity like we're doing today. Thank you so much. And we need to promote U equals U and continue to communicate it the way that we talked about earlier. And we need to use U equals U in our advocacy to show that it's a win-win when people have access to U equals U. We stay healthy, economies stay stronger, the health burden costs are reduced, and we accelerate towards ending the epidemic. It's an exciting time to be living with HIV. There's many resources to help you communicate, particularly for healthcare professionals, from Terence Higgins Trust, IAPAC, and ASHM. You can find these on our website. We have a searchable database where you can search by country, by language, by date, by source, flagship sources if you want to see what the WHO says, or CDC, or PEPFAR, or Public Health England. You can find those. So thank you so much. This campaign, U equals U, has blossomed into a global movement in 105 countries. And this is because of extraordinary partnerships with folks like all of you who are watching. So we really need to work together to ensure that people living with HIV no longer carry the shame and burden of HIV stigma. And we can do that by coming together and changing what it means to live and love with HIV around the world. Thank you so much for joining us today. And thank you again to ViiV for this wonderful opportunity and all of your groundbreaking work.
I'd like to thank all of my speakers today, and including Daniel for his time doing those videos and sharing his artwork. We did have some questions. Unfortunately, we have come to time, but I do want to mention some of the comments. So some of them were some questions around the survey that Tamer had talked to, and had Tamer considered looking at faith and faith organizations and how we can make a difference there. Have we thought about smaller key population or key populations that are less likely to engage in these type of surveys, like Black MSM, who do need a lot of support? And what can we learn? What can we learn to overcome these challenges and make sure that we're reaching out to these particular populations? There was also some comments around Andrew's presentation and talking about the childhood experiences. I think that's often not really spoken about, and the impact on stigma. So thank you all for your wonderful questions. This video will be available on ViiV Healthcare's website, and we will send you an email when that's available. So thank you so much for joining us, and we hope to see you again in future in more of our events where we're trying to get to zero stigma. Thank you very much, everybody.